Thank you so much, Craig. And thank you all for the invitation here. I really appreciate being able to speak here at the Coagulous Anemia Patient Family Conference. This is actually my first formal CAF conference. I was at the TIF CAF last year, so I'm really excited to be here. And I really love the engagement between the patients and the families and the providers that we have at this conference in this community. So thank you for the invitation. I'm really excited to speak here today. My focus today is going to be on, let's see, do we have, okay, there we go, perfect. Is going to be on new treatment options for thalassemia, and specifically, I'm going to focus on this newly approved drug called Mitapivat. I'm going to give a brief background, expanding a little bit on what Dr. Badawi just told us about thalassemia and some of the data suggesting transfusion thresholds, a little bit on luspatercept briefly, and then mostly on Mitapivat, and leave plenty of time at the end for questions for anybody that wants to know about my experience and any other aspects of the new medication. So as Dr. Badawi mentioned, thalassemia, as you all know, is on a spectrum, right? We have many patients who don't require transfusions at all, and those who require transfusions for their entire life. And then many patients in the middle who might need for specifically occasional transfusions in the setting of infection or pregnancy or surgery, or more regular transfusions for symptom control. And this is, this classification that we have of non-transfusion dependent thalassemia versus transfusion dependent thalassemia, or NTDT versus TDT. And this overlaps, just to say out loud, with the older terminology of thalassemia intermedia and thalassemia major, but the preferable term that many of us use on the clinical side at least now is NTDT versus TDT. It is important to know that this is a little bit of a subjective discussion, at least initially, right? Because one provider or one center might say a patient is NTDT and another may not. So I think it is really important to be seen at least one time at a comprehensive thalassemia center to evaluate whether the diagnosis and classification of your thalassemia is appropriate for you. And I think we're learning much more about this idea that Dr. Tom Coates terms dominant thalassemia, where it may in the past have been termed thalassemia trait, but really there's more than that, and Dr. Badawi mentioned as well, where you have lower hemoglobins that may require a little bit more diagnosis to understand exactly what your thalassemia means for you. We've made a tremendous progress in the treatment of thalassemia over the last 50 years. First with the advent of regular transfusions. One of the big barriers was iron overload. As we heard, cardiac iron overload is a huge barrier for many patients before the advent of iron chelations. And once we had the approval of Desferal in the late 70s and mid 80s, and then subsequently Deferiprone or Feriprox and Deferasirox or Jadenu into the 90s and 2000s. This has transformed the management of thalassemia and allowed for essentially a completely normal lifespan in patients with thalassemia who are regularly transfused and who are well chelated as far as their iron chelation. And this is something we kind of knew as a field, but really was definitively shown by Dr. Musallam, published a year or two ago in Blood, where if we target a pre-transfusion hemoglobin in transfusion-dependent thalassemia of greater than 9.5 to 10, that essentially predicts a completely normal lifespan for our thalassemia community, which is amazing transformation of care in thalassemia. It's really important to know also that higher hemoglobin thresholds do lead to improved outcomes in patients with NTDT. So this is Dr. Taher looked at a few years ago, looking at the Optimal Care study, where many of the complications that we see in patients with NTDT, including extramedullary hematopoiesis, which you just heard about, increased pressures in the heart and heart failure, the risk of gallstones or gallbladder removal, ulcers in the leg, and things like bone mineral density loss, osteoporosis, which you'll hear later on today. All of these are reduced in patients with NTDT who are regularly transfused versus those, in red, versus those who are either not transfused or only occasionally transfused in blue. And this is not just transfusions, however, this is actual hemoglobin values. So Dr. Coates, in a commentary for Dr. Musallam's article a year or two ago, looked at patients with hemoglobin levels greater than 10 versus those who have hemoglobin less than 10 with NTDT, and the risk of complications in these patients was significantly higher In the blue line, you can see this is what's called morbidity-free survival. So essentially, patients who don't have complications. You pretty much no patients or very few patients have complications with higher hemoglobins in red, whereas many do with lower hemoglobin. So targeting a higher hemoglobin and NTDT is really critical as well to prevent the formation and development of many of these complications that we might see. So what do we do outside of transfusions? Because I could talk for a whole hour on transfusions, but that's not the purpose of the talk today. It's the question is, how do we either augment or even potentially replace transfusions in patients who need higher hemoglobins and need better disease-directed care for thalassemia? So I'm going to talk about pharmacologic therapies here, including briefly on luspatercept or Reblozyl, and mostly on Mitapivat or Ecvesme. Gene therapy we'll hear about a little bit later today, and some of the options there, but there are 2 FDA-approved gene therapies, Beta-cell or Zynteglo, and Exa-cel or Casgevy. So first, I'll talk a little bit about luspatercept. So this is a medication that targets a pathway in red blood cells called the TGF-beta pathway that helps produce new cells. So we know, hearing from Dr. Badawi and from studies in the field, that one of the major underlying core reasons why thalassemia patients develop symptoms and develop complications is this imbalance between globin chains. And that leads to ineffective red cell production, or what's called ineffective erythropoiesis. One of the blocking pathways that prevents these cells from fully maturing is this TGF-beta signaling pathway, among others. And so the idea with this medication is if you could prevent that block and make more red blood cells come out into the bloodstream, that could increase hemoglobin levels and overall improve treatment of thalassemia in our patients. And this is an infusion or an injection that's given every 3 weeks. So this was studied in the BELIEVE trial, which is a phase 3 trial that looked at randomizing patients 2-to-1 to receive either Reblozyl or luspatercept every 3 weeks, along with transfusions, or placebo, a sugar pill, essentially in this case a sugar injection, or an injection that doesn't include the drug. And they looked at the reduction of transfused units, and their endpoint was reducing the number of transfused units by 1/3. And so essentially, if a patient normally receives, say, 3 units in a month, they would receive 2, or 6 units a month receive 4, and that would be a positive outcome for the study. Importantly, in this study, they only studied patients with transfusion-dependent thalassemia, so did not include NTDT patients, and also looked at patients with beta thalassemia, not alpha thalassemia. There is some emerging data that I won't mention today, but was released by the company that made this, Bristol Myers Squibb, that there might be some positive data in alpha thalassemia, so more to come on this potentially. But what's been approved so far is the treatment of transfusion-dependent beta thalassemia for luspatercept. And the study, they met the primary endpoint in this study, looking at patients who did achieve this reduction in transfused units. About 20 to 25% of the patients met this, and much less with placebo. This was true in patients with all genotypes and subtypes of beta thalassemia. And generally, it was well tolerated, but many patients did have complications as far as side effects, including bone pain and joint pain, which can be limiting, and we'll talk about in a little bit as well. So this was approved by the FDA for the treatment of transfusion-dependent beta thalassemia in 2019. And we have many patients on it, and there are patients who have excellent responsiveness to it. However, I would say there are some drawbacks to this. It does require an injection or an infusion every 3 weeks in clinic. Some of our patients have been able to get this done at home through home infusion, which can be beneficial. But the fact you have to come in for many patients every 3 weeks to the clinic makes it difficult to space transfusions out because you have to be there anyway to be able to get the infusion. The side effects can be limiting, so I can say that the bone pain that patients have with this medication is real, and it's very limiting, and it's in very unusual places in the body. Many patients will experience bone pain, particularly in the face and the jaw, and unusual spots. Kind of makes sense biologically because this medicine is pushing red blood cell production in more spots and in more bone marrow spots in the body that normally wouldn't make blood. So I think this is probably a function of the drug itself, but it can be dose limiting, and many patients have stopped the drug because of these side effects. And as I mentioned before, it's not currently approved for patients with alpha thalassemia, although there is some data suggesting that might be beneficial, or it has not been studied in patients with NTDT. So what's the alternative to that? And so there have been several companies, including Agios, as well as Forma Therapeutics, now Novo Nordisk, that have looked into pushing a pathway in the red blood cells that can help increase energy levels and improve hemoglobin levels in patients with thalassemia. So this is a complicated graph that is not important, but more to say that it is one of the major ways that red blood cells get energy is something called glycolysis. And how this works essentially is that you take glucose, sugars, and make it into pyruvate and then lactate, which is another form of a chemical that is used for further energy production in the body. In doing so, you make ATP, which is the major form of energy in the body. And so the idea is that there were patients with another red blood cell disorder called pyruvate kinase deficiency, which was missing this enzyme that was required to change pyruvate to lactate. And so the idea is several companies developed a drug to try to replace that enzyme that was missing or changed in some way, and that is approved for the treatment of PK deficiency. But the idea came about that, well, okay, maybe we can use this same drug to help increase levels of energy in red blood cells to help increase hemoglobin and, in any kind of hereditary hemolytic disorder, including thalassemia. So this was studied with Mitapivat for the Agios compound and then Mitapivat for the Forma and Novo compound. And the idea is that if you give this, that you would increase energy levels in the red blood cells, ATP. And in doing so, you can reduce stress on the red blood cells, reduce potential damage to the red blood cell membrane, increase the binding of oxygen to hemoglobin, make the cells more oxygenated. And that would lead to less ineffective red cell production, so more effective production of red cells, an increased lifespan of red blood cells, both transfused blood cells and in patients that make some of their own red blood cells, thalassemia intermediate, it might help increase the durability and longevity of those cells. And in doing so, decrease anemia and increase total hemoglobin levels is the kind of the conceptual idea behind how these medicines and compounds work. So this was studied in both NTDT and TDT patients. So I'll go through the NTDT data first. This is called the ENERGIZE trial. This was a 2-to-1 randomization with patients to receive a twice daily oral pill, so it's not an injection or infusion, but a pill, Mitapivat, at 100 milligrams versus a sugar pill. And this studied over 24 weeks, and then essentially the study investigators included both patients with alpha thalassemia and beta thalassemia, and in patients that were non-transfusion dependent in this study. And so the data is shown here. This is something called a waterfall plot. So each of these vertical lines that you see here is one individual patient. And the line at 0.0 on the vertical axis essentially shows you that's the change in hemoglobin from each patient's baseline. So the endpoint of the study was to try to get individual hemoglobins for patients at greater than 1 gram per deciliter above their individual baseline. So above that dotted, essentially the line above the dotted line. And they found that 42% of patients who were on the Mitapivat arm achieved a hemoglobin increase of greater than 1 gram per deciliter from their baseline with Mitapivat treatment. Only one patient did this in placebo. So it's highly statistically significant. And I would say that if you look at the data, even patients that didn't achieve that full 1 gram per deciliter increase did see meaningful increases in their hemoglobin, many above 0.5 grams per deciliter as well. And there's some data emerging that was presented recently at the EHA conference in Stockholm that shows some patients, even who didn't see a response in this initial 24 weeks, did see a longer, further out, saw a statistically significant increase greater than 1 gram per deciliter. So there might be even benefit beyond this 24-week period. So very exciting data for the NTDT community because this is a pretty impressive response in a large number of patients. This is true across any age range, any baseline hemoglobin level. The worry that maybe we had is that if your levels are lower or higher, do you see less of a response? That doesn't seem to be the case. Different areas of the world, different races and genders all showed responsiveness, which is very exciting. And the rapidity and the durability of this was durable for a long time. So the increase in hemoglobin was seen very quickly within 4 weeks and was durable out to the 24 weeks of study. So long-term did show evidence, and the open label extension data that was published at EHA also showed a longer duration, even in the crossover from placebo to the drug itself. Comparing this to patients with transfusion-dependent thalassemia, or TDT, similar study design, except these patients were alpha or beta thalassemia who were regularly transfused, randomized to either Mitapivat or placebo. and looked at over a 48-week period. It's a little harder to measure this because we can't just look at increase in hemoglobin. Patients are being transfused at different intervals and different amounts. So the endpoint, the way that we say this study is a success, is whether we can reduce the amount of transfused units by half over any 12-week period in the study. And what they found in the study is that the 30% of patients achieved what they call this transfusion reduction response, that 50% reduction in transfused units. Some patients actually achieved transfusion independence, where they didn't need transfusions anymore. Many of these probably were thalassemia intermedia patients who started transfusions, but it is a meaningful number. And this was true across all genotypes and regardless of transfusion needs. Side effects were well tolerated. I think we knew this from patients who had previously been on it for PK deficiency and was approved for that. Some headache that goes away quickly, some small risk of infection and decreased sleep initially, and some fatigue. And discontinuation occurred in about 5 or 6% of patients overall. And I'll get to the other side effect, which is liver enzyme elevations in just a minute with the monitoring program. None of these toxicities have been dose limiting or limiting in my practice to recommend or prescribe this, but it is important to know what the potential side effects might be. So based on this, Mitapivat was approved in December 2025, just a few months ago. Unfortunately, the question I get asked all the time is, can we predict who is going to respond to this therapy? And the other question is, if patients are on Mitapivat and having a response, are they going to have the same response on luspatercept? Are they going to have the same response on Mitapivat if they switch over? And I can't really answer any of those definitively without trying. I know there's a lot of work going on at Agios and other folks' labs throughout the country and centers trying to understand biomarkers and predictors for who might be more likely to respond and to what degree, but we don't have that information quite yet. So the expectations real world is that for NTDT, we'd expect about 4 in 10 patients would see a meaningful increase in hemoglobin greater than 1 gram per deciliter, and a smaller subset would see a more modest response. And I usually expect to see a response pretty quickly within 2 or 3 months after treatment start. For TDT, it's a little bit slightly less responsive rate, maybe about a third of patients will see that 50% reduction in transfused units. And it takes a little longer for this to kick in. I usually will give it at least 4 or 5 months before I say whether patients see they have a meaningful response in their reduction in transfused units. But overall can be beneficial in both these subtypes. It is important to note the safety signal and the monitoring required for Mitapivat. So the other thing that was seen in the study for Mitapivat is that 5 patients, about 1 or 2% of patients, did see liver injury as measured by labs and markers, an increase in either liver enzymes or in something called bilirubin, which is made both by the liver and is present within the red blood cells. One patient did have really high levels of bilirubin levels up to 32 and required hospitalization. Importantly, though, however, all these cases occurred within the first 6 months of therapy. And all of them resolved completely off of therapy. So because of this, and because we wanted to have the safest possible way of monitoring this for our patient community, the FDA and Agios and all of our centers do what's called a risk evaluation monitoring program, or a REMS program. So this requires essentially paperwork done by both the patient and the provider for monitoring, and then monthly monitoring with liver enzymes and a bilirubin to look both at the indirect and the direct forms. Direct is more liver toxicity, indirect is more related to the red blood cells, for the monthly for the first 6 months. And then as long as everything looks okay with that, then the patients can what's called graduate from the REMS program and do not require monitoring anymore, specifically for the program. However, I would say that especially in TDT patients, we are monitoring labs every 3 to 4 weeks anyway, and this is something that I would always do in all my patients. So I think it's more potential of a burden or challenging for NTDT patients who aren't used to coming in monthly for labs. So it's important to let them know that this is required, and we're doing it really because we want to have the maximum amount of both understanding, is it working for patients, and is it safe? And so it's really centered on patient safety, and I think it's the right thing to do for patients regardless of whether this was a requirement or not. In terms of real-world indications, so Mitapivat is approved for both NTDT and TDT, regardless of genotype. I personally would, and this is what I practice at University of Pennsylvania in our practice, in our comprehensive program, that I would strongly consider, you can consider for any patients, but particularly in this subset of patients, for NTDT, Patients with a low hemoglobin, less than 9.5, or you can really, we know that based on the data from Dr. Coates and others, increasing hemoglobins to greater than 9.5 to 10 can be beneficial for preventing complications. If you're symptomatic and have a more hemoglobin closer to 9.5 to 10.5, you could consider it. Or if you have a lot of baseline red blood cell breakdown hemolysis, since this targets hemolytic pathways in many ways, you can consider that. Or if there's a lot of iron overload at baseline to help prevent some of the complications related to them. On TDT, patients on dual iron chelation, so if you are on, say, JDNU and Feraprox, both, you might want to be on just one and not two, so to be able to reduce the amount of transfused units, you could consider this to, arguably the safety profile of Mitapivat is easier to monitor and less toxic than some of the iron chelators, and so that might be a way to switch medications, but it's hard to say. But I think that I would consider it for that. Patients with volume overload, if you needed, say, 3 units and you couldn't tolerate it because you get really bloated and symptomatic, many of our patients encounter this. This could be a reason to consider this. If you want to extend transfusions, everybody wants to do this, right? And so this is beneficial, and so I think it would be very useful to do that, especially if you're a young professional working, really want to try to be at home and out of the transfusion and apheresis center as often as possible. And if you have a lot of alloimmunization, so antibodies related to red blood cells, because minimizing exposure to units over time can be beneficial for these patients. I would say I'm asked often, what do we do if you switch from luspatercept to Mitapivat? You want to wash out for 2 full cycles, 6 weeks is my practice. And if you're considering gene therapy, you would want to hold this for 30 days prior to collection, and then continue probably holding it until your infusion overall. Right, so in summary, we know that transfusion targets are greater than 9.5 to 10, improve outcomes in both TDT and NTDT, and transfusion remains the way to do this in most patients. However, we have new approved therapies for this to help achieve some of these goals. Either luspatercept, which has achieved this improvement of hemoglobin and reduction in transfusion in 21% of patients by a third with transfusion-dependent thalassemia, but may be limited by some side effects, including bone and joint pain. And Mitapivat, which had a slightly higher rate of success in reducing transfused units in transfusion-dependent thalassemia, and also is approved for non-transfusion-dependent thalassemia, does have a different side effect profile and does require this REMS monitoring for the first 6 months. But I think both are really excellent options for our patient population, and many more to come. I run a lab at Penn studying new therapies for thalassemia, and hopefully we'll bring some of these to a future conference here as well, and working with the rest of our excellent team, including Jenny Cohen, our thalassemia nurse coordinators here, as well as Aaron Cheng, who's going to be new faculty at Penn starting in September. Very excited to have him, and so we have a great team. Yeah. But I think a great team and a great community, and really I'm excited to be able to share this all with you, and I'm happy to take any questions. Thanks, everyone.
Dr. Peslak,
Hi, Doctor.
in the middle of the room.
Yeah.
First of all, thank you for your talk. I'll see you in your clinic for the first time next month.
Sounds great.
See you there.
Looking forward.
I've been starting on Mitapivat for about 3 months. My hemoglobin hasn't changed, but my absolute retic has gone up sort of 2.5 times. How do you sort of read that data?
It's an interesting question. I would say that, so the one thing that and we could talk for a long time on this, and Dr. Cheng actually is really involved in this work as well, is trying to understand, is all hemoglobin created equal, right? So I think we have data that's emerging. We have a registry that's between Penn and Children's Hospital of Philadelphia studying not just hemoglobin, but markers of ineffective red cell production in many patients on all kinds of therapies, luspatercept, Mitapivat, gene therapy, allotransplant, transfusions, healthy donors. And I think there's data starting to emerge that maybe, what we know so far and what's been reported on is hemoglobin, but I think there's other things that, patients know and patients feel that we are just starting to be able to measure. And so, if you see an improved reticulocyte count, that's reassuring to me, I would say, as far as responsiveness. And it's more about, do you feel better, and would it be reasonable also to think about looking at things like nucleated red cells on your labs to look for another piece of data that might help understand what your responsiveness is. But in my perspective, if you're feeling symptomatically better or you see any markers that are improving, I have continued patients on therapy. The reasons to consider stopping it would be side effects, obviously, anything REMS related, or if you see a decrease in hemoglobin or increased markers that would indicate stress, but I haven't really seen that in many patients so far.
Hi, doctor. I'm speaking for another patient that I know who is 50 years old. He started the Mitapivat, and his doctor took him off of his heart medication, and now he's having trouble with his AFib. Is that a normal protocol to do?
Yeah, I mean, I think the part I didn't have time to mention here is there are some drug interactions with mitapivat, and so certain kinds of medications might require alternative drugs to be able to ensure that mitapivat either doesn't decrease or potentially increase the levels of other medications that might interact with it via the same kind of enzymatic pathways. So I don't know, I can't speak to individual patients, but I would say that it does sometimes require a little bit of changing around of medications to ensure that the other medications patients are on don't interact with mitapivat in a negative way.
Thank you. So I'm trying to understand the 50% reduction in the transfusion-dependent patients. Does it, in effect, allow the patient who normally gets 2 units every 3 weeks to go to 6, or 1 unit every 3 weeks? Because the latter is, or the former, I guess, is much preferred.
Yeah, it could be either one. So I think it depends on the scenario of what the barriers are for each patient and what they are looking for. So I agree with most patients who are well transfused and achieving their target goals of greater than the minimum hemoglobin, right, pre-transfusion hemoglobin of greater than 9.5 to 10, would want to extend the time between transfusions. And I think that's absolutely possible with mitapivat. I would say other patients might be getting, every 3 weeks, but their hemoglobins are 9, and or 8.5, and I don't really want to go up on their transfusions because it might lead to more iron overload. It might lead to more complications. And so for those patients, I might want to keep their intervals the same, but improve their baseline pre-transfusion hemoglobins. And so I think it's very individual based, but I would say, and it's a mix of what patients want and what patients might need, but certainly extending intervals would be a goal for many of our patients, and would be, if we see a responsiveness, would be doable in this scenario.
Hi, so I've been on Mitapivat for 12 weeks and my hemoglobin is not changing. And especially I'm facing a lot of bone pain closer to the infusion date, and I'm on excessive painkillers. So should I just stop, or should I go on for it 3 more weeks or 6 more?
Yeah, I mean, it's hard for me. I can't speak to your individual case, but I would say that the reasons to consider stopping is if the side effects are impairing your quality of life, right? That is a reason to consider stopping. I think in terms of efficacy, it's probably a little bit early, 4 weeks a little bit early to know. So I think I have encountered this with many of my patients, is balancing the potential benefit as things kick in with the initial side effects can be challenging. I will say that I have had several patients who have had side effects that have resolved after about 4 to 6 or maybe 8 weeks. So there's a window where things might be have more side effects and then get better. But so I can't speak to individually for you, but I would say that it's still a little bit early to know for sure as far as the effectiveness with hemoglobin.
Okay, thank you.
We have time for one more question.
Dr. Peslak, thanks for being here with us. I have a question. So you talked about Reblozyl and then Aquasme. So I was on Reblozyl, and when I first started taking Reblozyl, I went 9 weeks without a blood transfusion. And then after about 3-4 times, it went back to 3 weeks, and it was having no real effect, and it was giving me bone pain. So me and my doctor talked about it, and we just decided to stop.
Yeah.
So do you think that Aquasme would be effective in somebody who's not had much success with Reblozyl?
Yeah, it's a great question. I think about this a lot because I've had several patients of my own who have wanted to or considered switching from Reblozyl over to Aquasme. We can't predict. I can't predict that ahead of time in any individual patient, but I would say that if you did not see long-term effectiveness with Reblozyl, it's worth. My opinion would be it's worth considering Mitapivat just because it can be beneficial, and just because you didn't see responsiveness with that drug doesn't mean you wouldn't with Mitapivat. It's a very different mechanism of action, so it would, in general, it'd probably be worth considering. Yeah.
Thank you, Dr. Peslak. We appreciate it.